I'm somebody who sees about, I don't know, 20 to 40 patients per day, every day, and I do that now for 30 or 40 years. No, not 40, 30, a little bit more than 30 years. And of course you become a professional by doing that. And you learn a lot about what the patient is saying. You learn a lot about his disease, of course, but you also learn a lot about the person itself. And what you have to develop over time is some skills. How to get the patient to tell you everything you need on information, but also to bring the patient to a point that he thinks he decides what you want him to do. Because to tell you the truth, you are not able to make a decision, except the doctor tells you you have 3 chances or you have 3 options: do nothing, get radiation therapy, or get a surgery. Okay, that very rare. Most of the time, and I'm a surgeon, urologic surgeon, most of the time you are not able to decide if you want to do it right, if you want to rely on scientific data, if you want to rely on what is published, if you want to rely on prospective studies. But the patient doesn't care about prospective studies. He only sees himself, and he thinks, my neighbor, he had a radiation therapy for breast cancer and that was perfect, so it must be okay for me. The problem is, she or he has a complete different tumor. So you need a lot of knowledge about tumor biology. Impossible that you know that. The MD doesn't know that. And the expert in an outpatient situation, he even doesn't know that. Germany tries to overcome this problem by actually organizing centers where a group of experts is sitting together, one from radiation therapy, from the radiology department, from radiation department, from surgical department, from medical department, and they discuss in an expert group what to do with the patient. But again, who decides? If the patient already decided, I want to have radiation therapy, even so all come to the conclusion that the best would be surgery, the patient's decision is the one that has to be done. And then we come to the point, and I have to say this because otherwise we get a mixture. Who owns the data? The patient. It's always the patient, even in Germany. You can't give away any data if the patient does not sign or accept it that you give it away. Sometimes he even has to sign it. He has to sign that you are allowed to do that. If I want to bring a patient to one of the tumor boards, first of all, I need 2 papers he has to sign, because this is German right, that he is okay with what I'm doing, that I bring his case to a group of people, of course doctors, experts, and discuss with them what to do in this particular case. But on the other hand, the question from Mr. Prell was correct. Who actually has access was a good example. Access and ownership is different. Who has access to the data and actually who overlooks all the huge mass of one person. If he is 92 years of age, I just did surgery on a 92-year-old man a week ago, and he is doing fine. And his file is this big. Incredible how many blood counts and whatsoever he had in his life. And the one who knows it best is the health insurance company, because he went to this hospital, to that doctor, and et cetera, et cetera. And I'm really wondering why the German government or even the European Union does not actually forces the health insurance companies to open their files to everybody, because we would learn a lot from this, and I will show you an example. And this is what's coming up in the future. So I have to give an MD's perspective on the changing patient, and I focused on the patient, how I see it, and this is what it tells us, everything. It's the demographic. To talk about empowerment of patients, etc., was not necessary 30 years ago, because your life expectancy of a man was about 67 years of age, and for the woman it was maybe 71 years of age. Today, the life expectancy of a 65-year-old man is 86 to 87, and of a 65-year-old woman up to 70 years is 93. Every second girl that is born today will actually become 100 years old. So we are focusing on something that is very special, and we will face a problem we really never, we thought about, but we really have no answers how to handle this. Because all these 100-year-olds, there will be some who are quite fit, but most of them will not be very fit, and we see them in the hospitals. This is the situation in Schleswig-Holstein. It's somewhat different from Germany, the rest of Germany, because within the next, 10 years, within the next 10 years, more than 1/4 of the Schleswig-Holstein population will be older than 65 years of age. And this is 15 years ahead of Germany. Germany, the rest of the German population will follow until 2040. That means that in Schleswig-Holstein we have a laboratory. How we handle this problem. How we handle the 100 years olds. And why Schleswig-Holstein? A lot of people, and I was always wondering when I came to and moved to Kiel. I saw patients who originated or actually lived all their life in Dortmund, Köln, Cologne, Munich, whatsoever, and when they got older, they came to Schleswig-Holstein. Close to Denmark. Maybe that's why, I don't know. I think it was the weather. It was not so hot. It's cheap here. It used to be cheap. It's becoming quite expensive already on the coastline. So they bought apartments, smaller homes, etc., and that was more affordable over here than it was, let's say, for example, in North Rhine-Westphalia or in Bavaria or somewhere else. And they liked the scenery. They liked the ocean, the Baltic Sea, whatsoever. Several reasons. And that's why we have such a movement. We are missing the group between 25 and 55. This is our big gap because we have no industry or minor industry. It's a big problem here in Schleswig-Holstein. But that's a different story. So this is the situation right now, and they are well educated. When I say well educated, I mean they know exactly what to do with a computer. And guess, if you don't know, how many percentage-wise, how many of the Google researches include something that has to do with health? How many percent? 10%? 60. Who said 50? 60. 52%. Good guess. Of all Google researchers worldwide, 52% only have to do with health. Maybe sometimes it's just health food and how can I get, I'm now 90, how can I get 100? Or I don't know what they ask, but it's interesting to see that. This fantastic, isn't it? It's great, I think. But when we get so old, which is a very nice thing, we also face other problems. And here you see just the next 25 years, development until 2040. We will increase, as I showed you, the number of old patients by 36% up to 28 million in Germany. And that means that we will increase the number of incontinent patients above 60 years of age to 3.23 million. It's probably much higher, just to talk about urinary incontinence. So not always cancer. There are many, many other problems we will face. Alzheimer's, dementia, diabetes, whatsoever. So we will really face problems in the future. What does that mean when it comes to cancer? And to give you one example, as a urologist, of course, I talk about prostate cancer. What it means for the healthcare system. The prostate cancer is the most frequent solid tumor in a man. In 26%, it's the same in Denmark as it is in Germany. And of course, it's the same in the US. And it induces 10% of cancer deaths every year. That's what we need to know. The number of diagnoses increased from 1980 until now by 200%. And in the age standardized incidence rate, it increased by 110%. And it's ongoing, this increasing figure or line. It's also interesting to see that in younger patients, the mortality rate for malignancies overruns already the cardiovascular mortality. And this has also to do something with the new modern medicine because you put in stents, etc. So a heart attack is a death from a heart attack is not a very rare situation, but you can overcome this. When I was a young boy with 13, 15 years old, it was a normal situation that, for example, the father of my friend turned 65. 2 years later, he died of a heart attack. So he retired with 65. 2 years later, he was dead. That was the normal situation. Now we have a very excellent, as you probably have, or I'm sure you have it as well, it's an emergency situation, emergency center. Germany has, I think, the most and highly developed one in the world with helicopters, and they bring you here and there, and usually you can't die from a heart attack if it's not a really strong one. So we have to think about something else, how we get rid of this person. And the demographic development will further increase the prevalence and incidence, not only of prostate cancer. You can do the same with breast cancer. You can do the same with colon cancer. You can do the same with lung cancer. But it's so significant when you talk about the tumor for the man. I could also choose breast for the woman, where we have such a high number of cancer patients every year. The problem is, for us, it's great. I mean, I'm a doctor, I'm a surgeon, a lot to do surgery, a lot to treat patients, wonderful. So until I'm 100, I can practice because there are so many patients, they will not be able to handle this problem. And this is really the truth. We will not be able to handle all these patients. And the reason for that is, since 1991, and that was an official guideline, the German government decided we have to reduce the number of hospitals. And that's what they did. They reduced it from 2,500 to 1,979, and we are on our way to reduce it to 1,600, maybe 1,500, something like this. This is what actually every government, whether it's red, green, blue, yellow, I don't know, purple, they all want to do this because they believe they save money. Wait a minute. I'm not ready with my... Have you seen what we are doing at the UKSH? The whole hospital is under construction. We are expecting all these patients. But no, you're right. This is one of the points. And you see how the number of patients increased the same time. So the workload for the nurses, the doctors, for everybody, for all health professionals who are working in this field is getting bigger and bigger. And it's almost not standable. We have serious problems with the nurses on the wards because they cannot handle the work anymore and the workload. And there's another reason for that, and this is how long does the patient stay in hospital? He used to stay about 14 days. Now it's, what is it, 1, 2, 3, 5, yeah, it's 7.5 or so. So 7 days. So we cut it by half. And that means you see double the number of patients, more patients, and everything has to be done. So if we don't use intelligent systems like e-prescription, e-files of the patients, we are not able to handle this mass of patients. And this only includes the patients right now. We are not talking about those who will turn 100. Then we run in serious problems. The next problem in Germany is that we didn't increase the number of educational places. In other words speaking, we only have, what is it, about 12,000 medical students per year in Germany, 11 to 12,000. And this is not sufficient because here in Kiel, for example, 70 to 80% of all who start studying medicine are women. Nothing against women. I have a lot of women in my department. And they are brilliant. They don't fool around. They work hard. They are intelligent. They do their work. They finish their medical school. If we are lucky, they start with their specialization, but they won't finish it because they become pregnant, they become mother, they want to have a family life, and this doesn't fit in a world of surgery, for example. It's absolutely impossible to do that all at the same time with the same enthusiasm. It's not possible. So you have to make a decision. And that's why only 20 to 30% remain in our medical system. And all the others, they disappear. Some go to insurance companies, others go, I don't know, different ways, or they finish completely. And this is a major problem because in 3.5 years already, we are missing 40 to 50,000 doctors in Germany. And this is a conservative calculation. If we do an aggressive calculation, we are talking about 110,000, which we need, but we don't have. And I do not believe that all the people from Syria are able to do that. Maybe some. We try to include them. But this will not solve our problem. So if you have somebody left from Denmark, send him over. We will educate him. But to come back to my presentation, what I should talk about, I said, okay, how does the patient find the right doctor, the specialist, or the hospital? And I said, okay, we have 3 types. One was yesterday, which is still present. It's reputation. Patients come to me because I have a good or bad reputation. And recommendation, it's more or less the same. Because the neighbor said he did excellent surgery, was so nice, the nurses were so nice, and the food was excellent. It's also an important issue. It's not so much what you did inside, it's more so much what he puts inside, and then he says was a good hospital. Anyway, this will also change. This takes years because PR was not allowed. It's still not really allowed, but you can't really handle it. I mean, everybody is using a homepage and videos, etc. So everything is accessible. And what Mr. Prell said was correct. Pharmaceutical companies are not allowed during an exhibition to present the data about the special substance, Viagra. Not allowed to tell the patient what it does and what's behind it and where are the risks. They only can do it with special patient-related explanation or flow sheets and whatsoever. Which is crazy because if the patient goes into the internet, he can read all of them. It's all available. So we are somewhat crazy what we are doing here. But anyway, this is a different problem. So you can also go to the doctor or the specialist just around the corner. He already took care of my mother and maybe even of my grandmother, and now he is 65. He must have a great experience. I also go there. And he will tell me whether I should have a proton therapy, a Da Vinci radical prostatectomy, or if I get some very special personalized chemotherapy. Do you believe that the 65 or 70-year-old MD can answer this question? I answered the question for you. Impossible. He is not able to do that. Even the specialist is not able to do that. You can also use online gateways. Perfect. I used one before I prepared this presentation. Yameda is one that is used in Germany. So all the specialists who are in private practice are in there. So you click and say, wow, he is the number 1, I go there. I don't know how you actually got to number 1 or number 2. Anyway, Weiße Liste, it's another one. You probably have all similar ones, which just have other names in Denmark. You can also use yellow press articles. The most important yellow press when it comes to healthcare in Germany is Apothekenumschau. So you can get it for free in the pharmacy. And you have a lot of information in it, what to use in winter time and what you should eat or what you shouldn't eat, what you should drink. Sometimes you find an article from a doctor, very interesting to read. Sometimes it's a good one. Very often it's something even I haven't heard of. But anyway, maybe it helps. If you believe in it, then it's okay. And some print media reports, they also may help the patient. And he says, I saw something or I read something in the Bunte, so he must be the expert. I call these patients the believer. But he is stupid. Because he never really thinks about his health, his own health. He believes what somebody else tells him. But I ask you, who knows it better than you by yourself or the patient, how good he feels and what's going wrong? So he has to take care of himself. And that's what we have today. It's still reputation and recommendation. Nothing against it, but it's fast moving. PR via Google, via YouTube and whatsoever. Focus, we have a focus list. Have you ever heard about the focus list? Focus is like Time magazine. in Germany. In Germany, yeah, and they bring up a special list of the best doctors in Germany. Of course, I'm member of this group, 2,500. So I'm one of the 2,500 best doctors in Germany. Can you believe that? And now I'm standing here and talking to you. We ate this, but there might be something okay. For me, it was okay, yeah, but for the others, I don't know. What I would say is you really don't know how these lists actually are created. Very difficult. But some people believe in it. And there are many others who do similar things. But focus is quite popular. Every patient now, I would say, at least with a cancer, is using internet, and he gives in internet keywords, Facebook, and then he is lost. More or less, he's lost. If he doesn't know what exactly he is looking for, he is completely lost in the internet. He can use YouTube, which becomes more and more popular, particularly when it comes to the point, I want to have surgery, or I need surgery. Who is the best surgeon? Everybody wants the best. I want the one who knows it the best and can do it the best, but who is the best? We have to define who is best, what is best. And if, of course, paid selected articles in serious newspapers or serious journals could be something. And very often that's what I experience, because when patients come and they have a prostate cancer, they come and they have a full package of printouts, and they know exactly what I should tell them they need for treatment. And these are the self-made docs. They know it better than any other doctor. And many of them are in a situation where they are perfectly prepared, and you cannot convince them to do a different thing. Okay, but what comes next? Tomorrow. And that's what we are working on with this PROMETHEUS project. It's still reputation and recommendation. If somebody is really good, patients will find the way to this person. No question. But it's extremely fast moving. It's transient, and you have to do something for it from a doctor's point of view. What we need and what we use is patient-oriented information videos on YouTube, for example. I will show you an example. Quality reports on insurance companies, clinics, whatsoever. You will see one. Surgeons and others underlie quality control. We will have to face the situation that we also have to go through a yearly or biannual quality control of our surgical skills. Why not? Every pilot has to do that. Only in highly specialized medical centers. You're right. It's over with I do 10 a year. These are the serious surgeons or researchers. And that's what already started.
In diesem Video spreche ich über die radikale Prostatektomie, der gebräuchlichsten Form der definitiven Prostatakrebsbehandlung. Bei der radikalen Prostatektomie wird die Prostata vollständig chirurgisch entfernt.
Traditionnellement, cela se fait par une incision du nombril jusqu'à l'os de la ceinture pelvienne. La prostate est enlevée complètement avec les vésicules séminales ci-jointes. Le plus souvent, il est possible de conserver les cordons nerveux qui déterminent l'érection. Les ganglions lymphatiques, éventuellement atteints du cancer, sont également enlevés.
Следующим этапом мочевой пузырь и мочеиспускательный канал соединяются между собой тончайшими швами. Наконец, в мочевой пузырь устанавливается катетер, как правило, до 2 недель. Если мы знаем, что опухоль уже инфильтрировала капсулу предстательной железы или что поражены лимфатические узлы, мы можем своевременно и эффективно назначить и проводить необходимое дальнейшее лечение.
Deze urinaire incontinentie lost zich normaal vanzelf op. Na afloop van de genezingsproces ergens tussen 6 en 24 weken. 3 tot 6 maanden na de operatie raken alleen nog 2% van onze patiënten af en toe nog urine kwijt.
Gerade durch die neuen Technologien sind Kontinenz und Erektionsrate nach operativer Entfernung der Prostata exzellent. Für mich stellt die roboterassistierte Da Vinci-Prostatektomie die beste Therapiemöglichkeit bei Prostatakrebserkrankung dar.
We are quite successful with this kind of, let's say, information. And it's not only about surgery, it also tells you what to do at the beginning. So if you have, for example, if the doctor expects that you might have breast cancer or prostate cancer, what kind of diagnostic tools do you need? And another important issue, the language is no problem. You just translate it. In Germany, it's not possible, and even the patient from abroad can sue you if you are not able to bring somebody who translates what you tell him about the medical process you are doing on him in his language. So if he signs it, makes no difference. Every judge will say, did you tell him what you are doing in his language? If you can't show it, that you actually did something like this, you are the one who made the mistake. It's not the patient. So we see a paradigm shift. And for example, and this is one example, robotics will change our life, particularly in surgery the next years, but also the X-ray studies we will face in the future. The robots in the OR in the future, maybe it's this one. It will not. It will be still the surgeon. You all know this. I can shorten the whole thing. This is the Da Vinci system, which is the only available right now. And not only that, it allows you a much better skillful surgery on the patient, it is also much better in when it comes to, for example, complication rates. You don't make incisions anymore. But the most important thing is we don't want to see this anymore. And we don't do that. The infection rate, the wound healing infection rate decreased from 9% to 0.5% just by using this robotic system. And this is clear. So I would say everybody who is doing open surgery nowadays in those cases, that's a mistake. I would sue this guy if he didn't tell me that it's also available as a robotic surgery. And that's what's coming. And now we come to the next point. Not every hospital is able to finance such a system. And that's why we'll see a tremendous change. But also it allows quality control because you can video the entire process of the surgery. And you can see where the surgeon did a mistake. So you don't have to read the report, the surgical report, just watch the video. And that's what's coming. The next thing is that the patient will go home with a medical report, of course, but with a CD. And if something went wrong, he can go to a lawyer and say, let's have a look if everything worked fine. And we also, as I said, have the insurance company. And I left the German title, and that was presented just 2 months ago. And this is the first study that was ever done by a German health insurance company. It's called AOK, the biggest one in Germany. And they actually looked at 20,067 patients who underwent a radical prostatectomy in 245 different clinics, open surgery, laparoscopic surgery, and robotic surgery. This is not so important. I want to show you something. And that's what I mean. They have all the data. They have the data on mortality. They have the data on the transfusion rates. They have the data on re-intervention or readmission within the first year, within 30 days. They have it all. It's all available. And 20,067 patients, you don't have to argue whether this is relevant or not. This is highly significant, of course, because there are so many patients in it. And you see, again, robotics. So all the other procedures will disappear. Because if this is published, and it will be published probably before Christmas, then every patient in Germany who receives an open surgery once it was published, and the doctor didn't tell him that it's available in robotic surgery, can sue the doctor. Because it's published. And it's a difficult situation. It's not always good. It is a very difficult situation. Of course, we changed our mind and changed the situation, and you see that the graphs go up. In total, that is just kidney surgery. So we changed the entire surgical approach. So basically what we are doing is we are more or less just do robotic surgery if it's possible, or laparoscopic surgery if it's just for to take out the kidney. What about safety and future developments? And maybe I can show this. No, doesn't work, huh? Okay, anyway. What it shows is that you can use different dyes, and the dyes show you which one, once you clamped an artery, this is a kidney, where it's perfused and where it's not perfused, and then you know exactly the border where you have to dissect and resect the tumor, for example. And what comes next? It's augmented reality. Has anybody ever heard of augmented reality? Yeah. So you know something about it. Augmented reality means that the pictures one has taken, the MRI from your daughter, is put into the view of the doctor who is sitting on the console. So like in this patient here, you can see it, and then all of a sudden the picture of the lymph nodes will be included in what you see, even so it's artificial, and the study has been done before. And when you move within the body, the picture moves with you. And so you know exactly where you have to do the surgery. So it's less trauma. And patients will have access to all this information. They will ask for it. And if you tell them, no, it's not available, they say, I'm sorry, here is the publication, or here's what I've seen on the internet. What about economy? Because that also means economy. Now we come to the point where what the lady already mentioned. This is another good point to put it on. I'll give an example for the robotic surgery. If you do 100 cases per year with a robot system nowadays, I think it's also on radical prostatectomy, could be a mixture, and it costs you per each procedure 3,485 pounds. Or what was it? Yeah, 85 pounds. If you do it in 150 cases, it's only 2,323 pounds. But if you do 200 cases, it's only 1,742 pounds. And if you do 1,000 cases, then it's less than 1,000 pounds, what it costs extra. And that means it's impossible to have this available all over the country. You have to have centers, and this already happens in the States. And this is the trend, again, on the radical prostatectomy. The white bar, which you can't see nicely, I see it quite nicely here, very bright and clear. It ends here, and it used to end at 250 at the top of there. These are the low volume centers. Low volume centers means they do less than 15 cases per year. And this number is dramatically decreasing. This little one over here is a center that does more than 100 cases per year. And this one is increasing, it triples more or less within these last 10 years by number of cases. In other words speaking, we only will have treatment in centers, and the centers, of course, need to be certified. And we have a certification process which is already ongoing, so you become a certified prostate center, a certified colon cancer center, a certified pancreatic cancer, lung cancer, whatsoever, breast cancer. And only if you have the certification, the health insurance company will take over the costs. You can get surgery wherever you want, but then you have to pay by yourself. And this is a clear concept, and this every government, again, red, blue, yellow, whatsoever, wants to have this. Otherwise, we run out of range, because nobody will be able to afford what modern medicine actually costs. So medicine becomes transparent because it's all available, what I showed you, on the internet. The patient will know it, and it becomes easy, and we do better and we do good if we actually take care and prepare something that the patient is well informed. It can be checked all the time, because you video what you are doing. The same with any other procedure. If you do, for example, an X-ray or not an X-ray, a radiation therapy, even today it's already all in the internet, all in the database. You will find whether he got too much or too less. And of course it's verifiable, and you can compare it with other ones. So what I'm saying is it will become an open world. Medicine was always the doctor knows it and I know nothing. And it will change completely the opposite. That's how I see it as a doctor. And I think this is good, because a well-informed patient is much easier to handle. And he cannot argue that you didn't tell him everything, but you have to tell him everything. The problem is the day has 24 hours. And if you would actually discuss with the patient the treatment options for one cancer situation, it would probably take 6 to 8 hours. That's what a lawyer who actually has to deal with all these problems when the patient sues the doctor, tells us, and this is not possible. So we have to find a legal situation to limit this time for maybe, I don't know if we can do it time-wise, by 40 minutes, by 30 minutes, by 1 hour, I don't know. Or we have certified videos, like you have e-prescriptions. I like this. It's unbelievable that you have this. It's great. That patients are forced to watch the video, sign it that they have seen it, sign it that they have understood what they saw, and then you talk to him, let's say 20 minutes, and it's fine. Because otherwise you will always find a lawyer that can sue you, as we already have it in the States. And there it's even running crazy, because we have lawyers who are specialized to sue the lawyer who sued the doctor. Thank you very much.